Thank you, everybody. Good afternoon. I come from China. I come from Peking University Institute of Hematology. And today I will tell two stories about CLL. The first one is, why don't Asians get CLL? Another one is the CLL they get different than CLL in Europeans? And we come to the first one. The story started from 2000. At that time, there is a study conducted by Professor Gale, and at that time we found, although a lot of Chinese people or Asian peoples, they migrate into the US, into the Western countries, they still have very low incidence of CLL, almost 5 or 10 times less than the Europeans. And we come to the other cancers. First, as we have already known, it's a very high incidence of gastric cancers in Asians, especially those resident in Asia. If they migrate into the Western countries, the incidence will come low. And we can review the data come from the breast cancers. The story is totally different. If the people migrate to the West, they will have higher incidence. So that story tells us the incidence of those cancers might caused by the environment factors. But we come back to CLL. In the case of CLL, we can see all the Asians, no matter they live in Asian country or just move to the Western countries, they all have very low incidence. So I'm so sorry, until now we don't have any registry of CLL in China, so we don't have the correct number of the age-adjusted incidence of CLL. So we just use the incidence of CLL come from the SIA registry to calculate. According to 1.4 billion people in China, we times the 4.4 times per 10 to the 5th power, we can calculate there will be 616,000 newly diagnosed CLL in China per year. But we also have some colleagues sitting just with you, and according to our experience, every year we don't have no more than 2,000 newly diagnosed CLL in China. So where are those more than the half billion of those newly diagnosed patients? So I come from Peking University Institute of Hematology, and I think maybe you know we are a very big institute of transplantation. In our center, every year we will complete allogeneic transplantation more than 1,000. So that's the newly diagnosed hematologic malignancies in our center. We can see AML, more than 200, ALL, almost 100, and MM, we have more than 200. But CLL, we only have no more than 100. But in my experience, I think CLL patients are getting more and more. We can see this figure. The red curve just comes from newly diagnosed patients every year. We can see 2016, I have almost 80 patients newly diagnosed as CLL. And the blue bars just means the accumulated CLL numbers. In 2016, I have 400. So what happened? Maybe there's some publication also mentioned about the living style of Chinese people has already changed. That may be an increased epidemic because of environmental issues or something else. I just doubt it, and I also have the same feeling as my colleagues sitting with you, and we just consider that might be the bias of assortment. So I just analyzed my patients. I found More than 40 patients now, they came to me only because of the routine CBC count detection. And almost 1/3 of the patients, they just do the CBC detection because of other disorders, just like cardiovascular disorders, something. And less than just, there are less incidents, just a fewer patients came to us only because of the symptom, just like lymph node enlargement or splenomegaly, or just the anemia symptoms, something. So that's, I think, the main cause of I can see more and more patients in my clinic. So I just want to come to other causes of CLL. Actually, until now, we have exact evidence to demonstrate which environmental factors are the main cause of CLL, just like radiation, benzene, Agent Orange, or sometimes we just talked about is there any infections. And we just have a lot of feelings about genetics background, just like sex, not only in European, but also just talked by our colleagues in Africa, in India. We have the sex things here, more male patients than the female, and also we can see some patients come from the familial CLL. Just also some reports about ethnicity and also SNP, HLA haplotypes. I will come to the, here I missed a figure of map. That's the migration of the human beings. Not only Europeans, but also Chinese people and people in Asians come from our, the Africa area in more than 50,000 years ago, 50,000 years ago, yes. And they came to the different areas, but the Europeans have more CLL susceptibility, but not the Chinese people and the older Asian peoples. So we just consider that must be something happened because CLL just occurs after human being reproduction. So it's kind of not the selective pressure to do such kind of things. So here we comes to the SNP detection. The data comes from HapMap project. We can see there are 6 SNPs related to the CLL incidence was detected also in the European people and Han Chinese in Beijing and also Japanese in Tokyo. We can find the high bars just come from the Europeans and the very low bars comes from the Asians. So we just consider, that's very strong evidence to let us know there is genetic differences between the ethnics. Now I will come to the second question, is the CLL different? I just have one colleague comes from India. I talked with him, he told me he doesn't believe there's the same disorders of CLL between the Western people and the Asian, especially in India. He said it's quite late stage and very severe symptoms and very short survival. And we can come to the Chinese data. I think some of the professors here has already known that because one of our colleagues just reported that several days ago. It's a collaboration between the very big institute of Nanjing and the Italy laboratory of Professor Robin Fo. And we can see there's a disparity of the IGHV usage. We can see the V169, which is related with very poor prognosis was quite high in Western people, but quite lower in Chinese people. And the Chinese CLL patients have much more patients with mutated IgHV. We just doing the detection of steroid type, we will found subset 2 is quite lower in Chinese people, but 8 is quite higher. Here I just reviewed the publications of cytogenetics. We can find almost the same of the cytogenetic abnormalities. And we have a little bit fewer patients who with the mutation of SF3B1 and a little bit higher mutations of MYT8A. And according to the data in our center, the age at diagnosis of Chinese people are quite younger than the Western people. We can see the age above 17 only account for 17%. But in Western people, I can know everybody very familiar with the median age of diagnosis of CLL is almost 70 to 75. But according to my experience, I think I saw more and more elderly people. That's the data come from our center. And the more elderly people, they tend to do the routine CBC count or just do the CBC count detection because of other disorders. So I think maybe in future we have the similar median diagnosed age as the Western people. And also the right stage at diagnosis, I don't think Chinese people were diagnosed at very late stage. We can see the stage 3 and 4 only account for very low fractions. And then I will come to the management of CLL. Actually, we have a lot of drugs and a lot of drugs on the way. Chlorambucil, cyclophosphamide, bendamustine, fludarabine has already launched in China for many years and can be recovered by the public insurance. And also ibrutinib. Ibrutinib launched in China in 2017. Until now, the Chinese government will cover all the patients at first-line treatment. And acalabrutinib and zanubrutinib and another local product, orelabrutinib, is on the way. They are doing their clinical trials to launch China, and also venetoclax. We don't have any second generation of anti-CD20 antibodies now, and we don't have any launched PI3K inhibitor, but nowadays we have several products just with the local production. They just doing the clinical trials. I will show you the ibrutinib studies. We just conducted many years ago to launch that drug in China. We just enrolled 131 Chinese patients. All of them are refractory and relapsed. And the design of the study a little bit strange because we compare the ibrutinib with rituximab, not ofatumumab or other treatment, because we only have rituximab in China without any other second generation. And we can see the PFS and the OS, I think is quite similar as the data come from the RESONATE. And zanubrutinib is on the way and might be launched next year in China. And it's also some report just presented in Lugano. And we can see very short-term follow-up, maybe a little bit further not heavily treated patients. So we can see a very good PFS curve there. So I want to summarize my talk. Today we just give you some feelings, some taste of the CLL in China, CLL in Asia. CLL is 5 to 10 times less common in Asians compared to the Europeans. And the reasons for this discordance is unknown, but must be genetic, not the environment. I don't believe that. And obviously the gap between the heat of the environment to the incidence of CLL is quite long. And CLL occurs after reproduction, so there is no select pressure to not have CLL. And Asians and the Europeans derive from a common ancestor. They all come from Africa. Because we have no population-based data from Africa, we cannot know if susceptibility to CLL was acquired by Europeans or lost by Asians. There's a selection bias 40,000 years ago, and according to the data comes from the IGHV diversity, we just doubted it. There must be something, just maybe the infection issues, be the main cause of it. Understanding why CLL is rare in Asians is the way to determine the etiology of CLL in Europeans. Finally, CLL in Asians is most similar to CLL in Europeans. I believe it's the same disorders. Thank you.
Thank you so much. That is good to know that you think this is the same disease in the Asians, yeah. But I'm so sorry, but of the interest of time, we have no questions, and we also have to delay the next session, which is a very important session you have to come to. So 10 past, you will come back. But I again will thank you a lot. Thank you.